And I used to be very disenchanted seeing patients in the office because I didn't see them improving at all. I didn't see their blood pressures improving. I saw them becoming more obese, more diabetic. And even though their LDL would drop, I could never correlate that LDL with any improved outcome in my patients. So it was only through like a personal experience that I found a low carb diet. I started looking into metabolic health. And what it was is that you see me about 145 pounds in front of you. You see my bicycle in the background. So I belong to a racing team. And even though I was never particularly heavy, I was up to about 175 pounds despite cycling about 1,000 miles a month. And I couldn't explain why am I getting heavy? And so one day I was listening to this podcast and some information that Chris Froome, who was doing very good in cycling at that time, he's a Tour de France cyclist, that he was a low carb athlete, that he improved his power to weight ratio, which means that the amount of power he can put for his own weight was quite high, and it improved with a low carb diet. So I said, let me try this. And within a few months, I was down to 160 pounds. But since then, I've come down to 145 with further fine tuning as I learn more. But I said, if this is so easy in me, why am I not trying it in my patients? And so I've pulled myself away from the cath lab. I've hired a couple of colleagues who do my procedures. And I spend the bulk of my time counseling patients. And it's a learning experience. I learn every day. When a patient listens to my advice and he loses weight, his blood pressure gets better, his sugars get better, he comes off diabetic medications, he comes off blood pressure medications, he feels better. That is such a strong validation for him that he goes and tells many of his colleagues saying that, hey, there is this doctor who's doing something different. So being relevant, being somebody who can actually improve somebody's health is such an important aspect. I'll just give you a small example. Cardiologists feel very good about themselves when they can alter somebody's cholesterol. So you give a statin to somebody and their LDL levels are 150. They come back in 2 months on a statin and their LDL level is 70. And both the patient is looking at a number and the cardiologist is looking at a number, and he says, hey, this is fantastic. Look how much we have improved your health. Except that I think that they are looking at the wrong marker. I think for me, the transformative experience is not looking at a number, but looking at seeing, hey, is this guy feeling better because his blood sugar is lower? Are his joints hurting less because he has lower weight? Is his blood pressure better? Is he having to spend less money buying medications? So I think those are better surrogate markers than a blood marker. And it takes time for physicians to do that critical thinking. And I really find that surprising about my subspecialty, cardiology, interventional cardiology, because we have been focusing on cholesterol, which is, I think, the wrong thing. I think cholesterol is more or less a surrogate marker for insulin resistance. And we should be focusing on quality of cholesterol, which is an indirect indication of how good your metabolic health is. And I am frankly surprised that my colleagues have not gravitated towards that and then still cling on to this lipid, heart hypothesis, which cannot be more wrong. A typical cardiology consult is that, Mr. So-and-so, your stress test is good, your ultrasound is good. Let's go up a little bit on your cholesterol medicine. Let's increase your blood pressure medicines. And by the way, eat a low-fat diet and exercise, and I'll see you in 6 months. 30 seconds. It would shock a cardiologist who would come to my patient visit because he would not have any idea as to what we are discussing in terms of insulin resistance, insulin glucagon ratios, inflammation markers. the Kraft insulin response.
Insulin-glucagon ratio. The ratio between two hormones, insulin, which directs fat storage, and glucagon, which promotes breakdown of fuel from the liver. The Kraft insulin response. This is a standard test developed by Dr. Joseph Kraft to measure blood glucose response to a standardized amount of glucose over a 5-hour period and includes measuring insulin levels. This allows an extremely early signal of type 2 diabetes.
He would have no idea what I'm talking about, whereas my patients will. So this is the kind of change we are seeing in the consumers, because people like you, many podcasts that come out, many YouTube videos that come out, the gap between a consumer who knows details about science and about his own condition and what the physician knows is narrowing. And that's what's going to improve people's health. And I frankly think that as far as chronic diseases is concerned, chronic diseases meaning management of high blood pressure, diabetes, lipids, the doctors, the mainstream medical profession is really going to get buggy whipped if they don't listen to the consumer. So LDL is considered to be the bad cholesterol. And total cholesterol and LDL track each other very well. Like, in other words, if you have a high LDL, you will have a high total cholesterol. The first basic thing we want to give people is that there is a lot of discrepancy between what mainstream medicine believes and what demographic data tells us. So let's take a population of 50,000 patients studied in Netherlands. This is the Hunt trial. 50,000 people over 50 years of age. And they were looking at their cholesterol, their total cholesterol, or you could call it the LDL cholesterol. Higher the LDL cholesterol, lower the mortality. Higher the LDL cholesterol, lower the cardiovascular mortality. So when you look at large populations of patients who are older, and older people are more at risk of heart disease, this does not jive well with the mainstream medical concept. If you look at works done by Ravnuskov and Malcolm Kendrick, they took 60,000 patients from different trials, looked at LDL and turned them into tertiles, the bottom 20%, the second 20%, the third 20%, and then the top 20%. And if I tell you that the top 20% had the lowest cardiovascular risk and the lowest mortality, then it would make you doubt your hypothesis. Is LDL really the bad cholesterol? Why are these people doing so well? If you take a look at the Monica project, now this is information from World Health Organization, 2008. You look at countries like Sweden, like France, like Italy, they have a higher fat intake, they have a higher total cholesterol. You take a look at Russian Republic countries, the Eastern European countries, they have a lower fat intake and lower cholesterol. So you should expect that people with low cholesterol and lower fat intake should have lower total mortality, lower stroke rate, lower cardiovascular mortality. But it was the exact opposite. People with the highest cholesterol in Sweden, in France, and Italy had lower mortality and lower stroke rate. Made absolutely no sense. Let's go further. Let's go to World War II Japan. World War II Japan had cholesterol levels that were very low. Yet the incidence of stroke was 10-fold higher compared to that of the United States. As Japan became affluent and they started eating animal products, the cholesterol went up. What happened to the stroke rate? Did it go up? No, it came down. So you should say, why are there so many black swans? Why do they not agree with the hypothesis that high cholesterol would cause high strokes and high heart disease and high mortality? Then you look at the LDL data from a biochemical standpoint. Why do we make LDL? What is the purpose of making LDL? LDL is a very important host defense mechanism because there's a lot of biochemical data that shows that LDL participates in neutralizing bacterial and viral toxins. And so it's a molecule that is providing host defense. What does LDL carry? LDL carries inside it antioxidants. Antioxidants are there to prevent you from getting burn injury, from oxidative injury. It carries CoQ10 in it. Is CoQ10 important? It's vitally important for our muscle function, for our brain function, for our heart function. Because without CoQ10, you cannot really burn fuel. That's a very important enzyme in the electron transport chain, just like you point out, to convert glucose and fat into usable energy currency. Cholesterol is vitally important for brain function. In fact, cholesterol is so important for the brain that it doesn't delegate the liver to make cholesterol. It makes its own cholesterol. I could never understand people saying zero LDL is good when you could see that it is performing so many biochemical functions. That the reason the LDL gets oxidized is to protect us from oxidative or burn injury. So, in other words, LDL carries vitamin E. It carries many antioxidants like vitamin E. It carries CoQ10. And the function of the LDL is to protect the rest of the body from oxidative injury. And when it gets oxidized, it's called oxidized LDL. And the body behaves very differently when it comes to an oxidized LDL compared to a regular LDL. The liver is picking up the regular LDL. The reason it's picking up the regular LDL is because cholesterol is a very expensive thing for the liver to make. And it takes the LDL so that it can recycle it, it can make bile acids so that we can absorb fat that we need. Whereas the liver will not take up oxidized LDL. The reason it will not take up oxidized LDL is because oxidized LDL is like an injured firefighter. If you go to the scene of a fire and you see firemen there, you're not going to say firemen caused the fire. The oxidized LDL was there at the site of the injury to dampen the injury. And the body has mechanisms to differentiate between regular LDL and oxidized LDL. And oxidized LDL gets picked up by macrophages. These are mechanisms through which our body removes damaged and dead material. Just like the US Army would not want to leave an injured soldier behind, the body is picking up an LDL, an oxidized LDL that has done its function, that has protected us. And it's going to deal with it in such a way so that it minimizes the amount of injury to our body. Now, let's look at it from the standpoint of therapeutics. There is a very strong incentive to treat people to reduce their LDL levels. And we should try to find out what is the degree of benefit. So I'll start out with the most ridiculous example. You take 28,000 patients. 14,000 of them, you give them a new drug, a PCSK9 inhibitor that drops their LDL to 30 milligrams per deciliter. 30 milligrams per deciliter is very low.
Yep.
Because you and I, if you're following a ketogenic diet and we are exercising, we are fasting, our LDL levels will be 200.
Yep.
So 30 is very low. And if you treat 14,000 patients who have high blood pressure, who've either had previous heart disease or stents, who've had previous strokes, who have had blockages in their legs, this is a high risk population. And you say, higher the risk, greater the benefit in terms of reducing LDL. And if you treat 14,000 patients and reduce their LDL to 30 milligrams per deciliter, and there is no impact on mortality. In other words, you don't reduce death rate at all. In fact, in the group that got given the medicines, the death rate is a little higher than the control group. You would say there is something wrong with this hypothesis.
Yeah.
So I want to break here, and I think we have beaten LDL so much and so wrongly And I think we have lost focus on how to improve somebody's health, because everything you do to reduce LDL is going to harm your body in terms of insulin resistance. When you remove LDL, your insulin receptor doesn't function well. Your insulin doesn't function well. Your muscles don't function well. Your brain does not function well. Although you have reduced the LDL, you have made insulin resistance and everything else worse. So, why is it that we are clinging on to a hypothesis that has produced ill health in so many different ways, rather than focus on root causes, which is what you are doing? It is very gratifying to a physician treating somebody to actually look at a blood test and say, hey, I was able to drop your LDL by 50 to 70%. That's gratifying both to the patient as well as to the physician, because it is so intuitive to think that, hey, the blood vessels are clogged with fat, and this man has reduced my fat by 70%. And that's a dramatic improvement. And so you gravitate towards that. The second is the way in which clinical trials have evolved. Clinical trials have been driven by the pharmaceutical industry. The clinical trials give a very misleading magnitude of benefit. Like, for example, I will take you back to 1994 when the Scandinavian simvastatin trial was done. Simvastatin is a cholesterol reducing drug. 1994, it was published, 4,444 patients, half on simvastatin, half not on simvastatin. This trial was completely done by Merck. Merck had the biostatisticians, they funded the trial, they collected all the data, they presented all the data. Even though the physicians presented the paper, the data was all gathered by Merck. So, in other words, the degree of conflict of interest was very high. There was a significant reduction in cholesterol, I think 25% in LDL cholesterol. But the most important endpoint was that if you treated 100 patients for 1 year, you would reduce half a death, zero. 0.6 deaths, half a death. So if your magnitude of benefit by treating 100 patients for 1 year in terms of mortality reduction is 0.6%, you should say it like that. You should not say that there was a 42% reduction in the risk of death and myocardial infarction, because that's a relative risk reduction. And relative risk reduction is very misleading. And I like to use Dr. Kendrick's example. Let's say if the Texas Lotto, to win it, the jackpot is 1 in 10 million. And you come and you tell me that, hey, I'm going to double your chances. I'll improve your chances by 100%. That 100% really is from 1 in 10 million to 2 in 10 million. But if you say it as 100%, it will sound a lot more impressive than if you say, I'm going to improve it from 0.601 to 0.602. So the way in which this data is being presented to physicians is wrong, because we focus so much on relative risk reduction. And we are very happy looking at surrogate endpoints of a reduction in LDL cholesterol. And the way healthcare has evolved is that physicians don't want to hear their patients' complaints. When the patient comes in and says, hey, I'm aching all over, they're not going to think that it is the statin that made them ache all over. It's saying, you're just getting old. You're not active. You should go active. You should eat better. If he says, hey, I'm forgetting things, and they would never attribute that to a statin. They would say, hey, everybody forgets things. So I think these are some of the reasons why the medical community is not doing critical thinking. I think we as a group have to move patients in and out, and it is much easier to counsel them on saying, take this pill, rather than to say, hey, look, let's have a real meaningful conversation about the degree of benefit of reducing your cholesterol and the degree of risk you can face. If I take somebody like you, I may put you on a cholesterol medicine for 50 years. Is that really fair for a physician to do without really getting into the real conversation? What is your degree of benefit? What is your degree of risk? And over what period of time do you face this risk? How many times is a cholesterol prescription given and a person is informed it may cause muscle aches and pains? Your diabetes may get worse. You may lose your memory. Your memory may go bad. Maybe your infection risk would be a little higher because we are reducing a very important host defense mechanism. And I think this is the real conversation that a physician should have, but they're simply not trained or equipped to do that or have an incentive to do it.
Yeah.
And I think that's the real failure of medical profession. Why are we spending so much money and we are not improving health?
Yeah.
Why do we have such better healthcare and we have rising obesity and diabetes? Why is our longevity? I mean, it is so saddening to see that for the first time in the history of United States, in the history of such a great country, that our children are going to live a shorter lifespan than us. You can get a little surrogate markers of insulin resistance by just looking at a cholesterol profile. Like, let's say you have one of your listeners listening in and they pull up your cholesterol profile and they're looking at their triglycerides and their HDL. If their triglycerides are low, which is fat in blood, and if their HDL is high, that means that they are insulin sensitive. If their triglycerides are high and their HDL is low, that means that they are potentially insulin resistant. Insulin is a key factor not only in controlling your blood sugar, but in also controlling the lipid metabolism. So, the health of your fat cells, how much fat you can pack into your fat cells, how much fat is released from the fat cells is also an important aspect of insulin. So, it is important for a physician to recognize how insulin resistant that person is. So, in simple terms, let's say you have a normal sugar of about 90 to 100. And if you are needing about 4 or 5 of insulin, that means that you need a low amount of insulin to hold your sugar there. On the other hand, to hold a normal sugar of 90, if you need 10, 15, 20 or higher insulin, that means you are insulin resistant because it's taking a lot higher insulin to keep your sugar levels in control, which is what most Americans are. So in other words, if you looked at insulin resistant in American population, the prevalence of resistance is perhaps 3 in 4. 75% of Americans need more insulin to keep their sugars in control.
What threshold would you say would be a fasted insulin level that you would say would be indicative of insulin resistance?
I would say that if your HOMA score is above 1 and consistently above 1. Now, insulin is a cyclical agent. In other words, the body releases insulin at baseline. Let's say you're fasting.
Yeah.
And the body doesn't release insulin constantly. It releases every 10 minutes. So 10 minutes it goes up and then it comes down. So it's a cyclical release of insulin. And the cyclical release of a hormone or a pulsatile release of a hormone is very important to prevent resistance of that hormone. Our biology is designed like that.
Yeah.
So within a degree of variability, in other words, like let's say if I take you and I check you at the peak of your pulse, you may be 10. And if I check you at the nadir of your pulse, that's the lowest of your pulse, you might be 2 or 3.
Yeah.
But I would say as a rule for health, you should aim for a HOMA score. 100 of insulin and 100 of sugar and about 4 or 5 of insulin. That's a HOMA score of 1 is probably a person who is insulin sensitive. Now that's only one marker of insulin sensitivity. Another marker would be the health of your fat cells. Because eating food is a stressful event for the body. And the reason it's a stressful event is because our body needs to keep a level of sugar within a certain narrow physiologic range. It needs to keep the levels of fat in a narrow physiologic range. It needs to take the protein that you have eaten and dispose of the amino acids into new protein, new muscle, or use it for fuel. So the body cannot vary the levels of sugar too much. Whereas we eat a huge amount of meal. A standard American may eat about 400 grams of carbs in one setting. So the body needs to pack the carbs. It needs to pack the fat. So the fat that you have eaten, the body takes that fat, it puts it into these fat globules called chylomicrons. They circulate in the bloodstream and they are cleared and packed into the fat cells in less than 5 minutes by insulin. Insulin has to activate an enzyme in your fat cells to do that. Now, if your fat cells are unhealthy, if they are overstuffed, then the fat remains in the circulation for too long because the fat cells say, hey, we are already too full. We can't take any more fat. And we want to become insulin resistant to protect ourselves. So the body starts over making insulin to pack more fat into the fat cells. And that is an important aspect for any physician who is treating chronic diseases to recognize that, hey, I want to check this person not just from a cholesterol standpoint, but I want to check them and see if they have too high an insulin. Are their fat cells healthy? Because high insulin will increase your blood pressure, will cause gout, will cause many other chronic ailments. And that's where our role is. That's where our role is in terms of educating the public to improve their health, not through medicines, but through a combination of diet, intermittent fasting, and exercise. Insulin to be released in a pulsatile manner is important for our biology because insulin is made in the pancreas in the beta cells. It's packed into these small granules that mature and they come towards the periphery to be released into the circulation. So the insulin producing cell has to take time to make those granules. If it's releasing continuously, it'll get exhausted. So it needs a period of rest. And the maturation of the granules is timed, it is cycled to in the resting state when you're not eating to about once every 10 to 12 minutes. Let's go to the insulin receptor, the receptor at which insulin comes and sits. And when the insulin sits on the insulin receptor, it activates a series of signals inside the cell. One of the signal is that it activates a channel through which the cell takes in sugar. It activates certain chemicals inside the cell. Now let's take a brain cell. Hippocampus. Hippocampus is the area in the brain that facilitates memory. Memory is vitally important for our human function. The hippocampus is very rich in insulin receptors. So insulin sits on the hippocampus and it activates a series of chemical reactions through which it makes new protein in the neurons. And these new protein increases synaptic plasticity, which means that it improves the connection between brain cells. So insulin is important for that. Now, the receptor gets inactivated for a period of time. It gets internalized, it's doing its action. It takes time for the insulin receptor to come back up to the surface of that cell in an activated form. What are we doing as humans to mess up with our biology is that we eat several times a day. We eat a large amount of carbs. None of these things are good for our human biology if we don't recognize how the human body works. Because if you're eating frequently, you're pouring a large amount of insulin into the circulation. Insulin was designed to be released infrequently, because when you have high insulin there at the level of the brain all the time, you're going to down regulate the insulin receptor. The insulin receptor is going to go inside the cell and hide. And this high insulin is not going to be there to do its action. You're not going to improve memory. In fact, one of the reasons why there is such a high incidence of age-related dementia in this country is because of brain insulin resistance. You have down-regulated insulin receptors in the brain, at which time you are no longer capable of forming the kind of connections between brain cells that you lose your memory. As soon as you eat food, even before the glucose gets into the circulation, the gut is already sending hormones to the pancreas, the GIP, that makes the pancreas know how much food is coming in so that it can prepare the amount of insulin it's going to release. It knows how much protein is coming in because the gut is signaling to the pancreas, hey, I'm going to dump so much protein into the circulation. It's also signaling how much fat you're going to send into this circulation. When we eat in a lot of fat, fat is pretty toxic if it is left in the circulation. In other words, if you were to give me a marker of health and say, take somebody with high LDL, I'd say, yeah, this guy's going to live long. But if you give me somebody with high triglycerides, which is high amount of fat in blood, I would say something is seriously wrong with this person's metabolic health and that they can get into trouble. What one may ask is lipotoxicity, and lipotoxicity is that in reality, whether you are a low carb individual or whether you are a pure vegan or whether you are eating a standard American diet, you're by design going to eat fat. And that fat is absorbed by the body in fat globules and it needs to be packed into the fat cells. And if your fat cells are full, if they are inflamed, if they are insulin resistant, what insulin resistance simply means is that the insulin receptor at the level of the fat cells is not working because it's down-regulated, because you've had too much insulin in your circulation for too long. And so the fat cell cannot take in the fat that you have eaten and it remains in the circulation. By the way, there can be several obese people who are insulin sensitive, whose fat cells are healthy, and then when they take in the fat, they pack it in quickly. So you can have a metabolically healthy obese person also. But if somebody is insulin resistant and obese, I would perhaps not advise them to eat a large amount of fat. These people may first need to improve their health through a regimen of fasting, through a regimen of protein sparing modified fast, through a regimen of exercise,